Okay, guys, I'll just send the link in 5 minutes to all the participants for the webinar.
And Kusha, Shefali asked me to keep an extra case just in case we have more time or the participants are asking for another case. So how
Yes.
much time is the ideal time for me to cover this whole
Okay, so
cases?
the ideally what we have told the participants is the session will be from 6 to 7:30, so you have all the time right now. We'll keep the MCQ quiz, I think, for around 30 minutes. Does that work with you guys? Because we have 14 MCQs, right?
15 MCQs.
Yeah, 15 MCQs. So 30 minutes works, right? So we give them like 2 minutes to attempt each
So I
MCQ.
should get it done with by 6:30. The
You can
cases.
get it done by 6:30, or you can maybe finish it by 6:45 also. And like
Okay.
after the, do you guys want to discuss the answers of the quiz? I think we
I prepared that.
perfect, perfect, great. तो उसके लिए there will be like 20 minutes का time, right, max for
So
every.
I guess 30 minutes is quite long. मतलब इतना ज़्यादा लगना नहीं चाहिए
हाँ
quiz.
मतलब पर अभी के लिए safe side के लिए let's keep it
अच्छा
30
अच्छा हाँ ठीक
and
है.
then yeah, perfect, ठीक है चलेगा.
And in case I do not know the answer to some of the doubts, then what should I do? Like, can I send the answers
So
afterwards?
in cases where you don't know the answer, it's totally fine. You can just say that we'll let you know what the answer is on the groups after the session is over. I'll also let them know if at all that something like
Okay,
this
okay.
happens. Not an issue.
अच्छा I
Thank you.
think जो last जो दो questions है that part Akash will take up.
हाँ.
Akash sent a message that he is quite tired after the workshop. So he was saying, अगर कोई question आते हैं तो please inform me beforehand.
Yeah. Just ask every one of your group to check, get into the Zoom at least by 7, so that अगर कोई question रहेगा तो तभी उसके बाद ही होगा वो, तो फिर there are no issues. उनके पहले अगर if they are very tired, make just tell them to get in the Zoom link at least by 7.
Kusha, can you please share the YouTube link as well on the group?
Yes, I'll do that. I'll just do that after I share the Zoom link, so that yeah. I think Gaurav had access to the original form. I'm just giving him access to the new one.
हाँ sure.
Okay, I'm sending the Zoom link to everyone now. Okay, I've changed the chat setting so that everyone can put their answer in the chat box.
Okay, thank you.
You're welcome. Hi guys, we're going to start the session in the next few minutes. We're waiting for a few more people to join in.
କରିବାକୁ ଭାବୁଥିଲା ଯେ ବମ୍ବେରେ ଗୋଟେ 3 ମାସ
Hi guys, we're going to start in the next 2 minutes. I'm just waiting on a few more participants. I'm hoping a few more join. And in 2 minutes, we'll start. Okay, guys, I think we're going to start. Welcome to the last day of SCOMEdipedia for CNS. We really hope that these sessions were really beneficial for you guys. Our Lomis have been working amazingly well over the past few weeks designing all of this for you. This will be the last session for CNS where we're going to cover cases, and we will also have a pop quiz. The link for the same will be sent only on the Zoom call, not on the group, because we want you guys to attend the pop quiz after you're done with the cases. And we'll give you a stipulated amount of time of around 30 minutes to attempt the whole quiz. And once that is done, you will receive your results immediately. The results of the quiz will not be a requirement for certification. You just need to basically attempt the quiz. So please don't be afraid to attempt the quiz. I myself, as a final year medical student, can tell you I do not know half of what was taught initially and before these sessions. So please don't be shy while you're attempting the quiz. Everyone is a panda here, and we are all here to make our medical education experience better. So we're going to start with the cases, and we hope you have a great time today. I think Shikha is going to start with the cases.
Yes, Kusha, am I audible?
Yes, you are.
Am I loud enough?
Yes, yes.
Yeah, so hello everyone, I am Shikhar Abbas. I am the first year student from Vardhaman Mahavir Medical College and Safdarjung Hospital. And welcome to the last day. And yes, happy Teachers Day to all of you. Yeah, so welcome to the last day of Vico Vets on CNS. And today I'll be presenting you some cases. Okay, but before that, I think I would like to thank Shefali a lot. Okay, she has been coordinating with us for the whole week and working with us. Only because of her only, we have made such beautiful presentations, and we have reached there. She has really beared with all of us. And I would also like to thank Kosha and Nishant for bearing with us and motivating us throughout the things. Okay, so I think now I'll be starting. And I'll be constantly looking at the chat box. So please try to be as interactive as possible and send as many answers you think are relevant to the whole thing. So thank you so much, and I'll be starting now. So guys, welcome to the Panda Clinic. Okay, the Panda Clinics, you all are doctors. You all are already MBBS doctors, if not of higher degree, and I'll be presenting you some cases. Following that, I'll be asking a very, very easy questions. Okay. And then I will be asking you guys, uh, then I'll be also telling you guys about the explanation of all the parts. Okay, let me set my camera once and let's start it now. So guys, I'm presenting to you the first case. I hope you'll be ready to type the answers, but first of all, we'll discuss what are the presentations and then I'll be asking the questions. Feel free to flood the chat box with relevant answers. I'll be looking forward to that. So guys, this is the first case which you can see on the screen. Okay, so this is a 55-year-old man. The features he's presenting are having a mask-like face. That means कोई expression नहीं है face पे. There is no expression on the face. Okay, we are already having amazing answers. Then there is pill rolling tremors of the hand. Please focus. Pill rolling means the tremors including your index finger and the thumb. Okay, as if you're rolling a pin. Okay, then the stooped posture is also there and the specific gait. So I think I'm already getting a lot of answers. So already the first question, which is on your screen, along with the results, I think that it is quite clear the answer is Parkinson's, also known as paralysis agitans or Parkinsonism. I'm very happy with the amount of responses I'm getting in the chat box. So thank you for all of that. Let's move on to the second question from the same case, guys. So I'll read the question for you, and I'm looking forward to the answer that I'll be getting. So, and I'll be explaining also afterward. No worries if you don't get it. Okay, please try to answer. What would be the cause of this disease that is Parkinson's? Is it degeneration of dopaminergic neurons, which are present in the substantia nigra, pars compacta? Okay, or is it can occur as a complication with phenothiazine group of tranquilizer groups and other drugs that block D2 receptors, mind you. D2 receptors are dopamine receptors. Or is it decreased inhibition remove हो रहा है and increased excitation from the subthalamic nucleus to the internal segment of globus pallidus, or is it all of the above? Okay, so I've got a lot of responses, but I won't say that most of you are correct over here. Let's see who gets the right answer. Now I'm getting a lot of correct answers. So guys, the correct answer for the question number 2 is D. Okay, because if you will look at these, actually all of these are interrelated. Okay, so the dopaminergic neurons, they are secreting dopamine. Okay, I'll be discussing the cause in more detail while I'll be explaining the whole concept. So no worries about that. So I'll discuss all of these then only. Oh, I hope that's all right with you. Moving to the third and last question from this case, can anybody identify this histological finding which is found in the substantia nigra of similar patients? Anyone? Amazing. I've got an answer from Ashwit Devan. Very good. And that's the perfect answer. And now I'm getting a lot of answers from many guys. Yes, it is. Okay, I'll be waiting for a few more moments because many people are trying their best to send answers as fast as they can. And yes, we are having a lot of answers in the chat box. I'm so happy about that, guys. The answer to the third question, as you can see, is Lewy bodies. Thank you so much for the answers. Okay, and these are nothing but they are round bodies. They are proteinaceous. Okay, and they are made up of which protein? It is alpha-synuclein. Alpha-synuclein is a specific protein whose function is not that clear till now. Okay, and remember they are eosinophilic, as you can see in the diagram. Okay, that's all I'll be discussing about Lewy bodies. Okay, and they appear in the substantia nigra in not just Parkinsonism, in other diseases also they have been observed. Okay, let's move on to the explanation of this case. I hope you're enjoying till here. So the doctors, all of you are here. You have given very nice diagnosis and also the findings which we were there on the patient. And now let's discuss what is the basis behind all of that I've asked you. Why is all that occurring? Why are the tremors happening? Why is the person having expressionless face? Let's start with the basics, guys. The cause of Parkinson's is nothing but the degeneration of dopaminergic neurons, mind you. This is the ultimate cause of Parkinson's. Okay. Now, this degeneration of dopaminergic neurons, which means neurons which secrete dopamine, okay, as the neurotransmitter, it could have various reasons, and mostly, sadly, it is idiopathic. We don't know what reason is there. Okay, so most of the times we don't know what the reason is. Okay, and other times it has been associated with the mutation in certain genes like PINK1, PARKIN, alpha-synuclein. You can always refer to the PPT afterwards as well. Okay, let's focus on the conceptual part here. Okay, and it can also occur to the toxic impurity MPTP. Okay, it is found in various recreational drugs, guys. Okay, and rarely due to this toxic impurity. Okay, usually the drug which we give is MPPP, but sometimes this impurity is found. Okay, and because of this also this degeneration can occur. Okay, and other risk factors also include pesticide poisoning and also some gene variants. Okay, but again, that is very, very rare. It is mostly idiopathic, that we cannot explain what the reason is. And I hope you will remember the ultimate cause is degeneration of dopaminergic neurons. Sorry for that. Okay, now this all is happening, but what the hell is this substantia nigra? I have no idea. Maybe not. Okay, most of you might be knowing, you are my seniors. Okay, but let me try to explain as best as I can. So guys, have you heard about basal ganglia? Please reply in the chat box. Have you guys heard about basal ganglia? I hope all of you have heard about that. Yes, I'm getting a lot of responses. And it is very, very important to understand what they are to understand Parkinsonism. So let's try to go conceptually, step by step, to understand this whole process. So I want you to listen very carefully this definition, that there are 5 large masses of gray matter. Okay, we know there are 2 types of matter, gray and white. The gray matter, okay, 5 large masses which are situated at the basal part of the white core of cerebral hemisphere. These things are located lateral to the thalamus. Let me use my pointer to see. Okay, guys, this is a section of the cerebrum. Okay, and as you can see over here, these colored structures which you can see, na, these blue, purple, and green structures, these are what we call the basal ganglia. Okay, and as you can see, they are lateral to the thalamus. Okay, now I will not be discussing all 5 of these basal nuclei. The ones which are of focus to understand Parkinsonism are the caudate nucleus of corpus striatum, okay, and also substantia nigra. Okay, these 2 are of our main focus. So I hope you will remember these 2 names while I'm going through the next slide. So please focus on this. I've taken this from a video of osmosis. I hope that's all right with you guys. So please focus on this diagram. Okay, normally what happens is, normally the dopamine is synthesized in the melanin containing pigmented cells of substantia nigra. Substantia nigra, as we all know now, is a basal nuclei, which is nothing but it is a mass of gray matter, nothing more than that. Okay, and in that we have various pigmented cells. That is why this region is actually very, very dark. Okay, because of this melanin present. Now what happens is, these pigmented areas secreting dopamine, and this dopamine will be transported through the nigrostriate fibers, okay, to the corpus striatum, which is another basal ganglia, as I've already discussed with you. Okay, so now what will happen, this dopamine is having inhibitory effect, inhibition on the corpus striatum, which is involved in various motor functions. Okay, now the neurological symptoms which are occurring, what happens exactly is, as we know, the second point which you can see, this transportation part, it has been stopped. Okay, I'll continue. So this part has been stopped. Now there is no dopamine going through the nigrostriate pathway because the amount of dopamine is decreasing. So what will happen? We will have various symptoms of Parkinsonism occurring. Okay, as you can see, the blue one, dopamine, it is going from the pars compacta. Pars compacta is the part of substantia nigra, mind you. Okay, and from this, okay, as you can see, the red, this blue one, this blue line which you can see, this is the nigrostriatal pathway, guys. Okay, and it is moving on and going to the corpus striatum, which again has various parts. Okay, to specifically to the putamen. Okay, now moving on to the next slide. Okay, I hope the concept is clear to you how this whole transmission is occurring. Now, the next thing that you need to understand is that this is the diagram which through which we can actually study, okay, what is happening. So this is what we call a single photon emission computed tomography SPECT. Okay, and it can show quite clearly. Okay, in which one, A or B, can you see less color? A or B, which one has less color at the center? A, and it's quite clear, as all of you are telling me in the chat box. Okay, I'm hoping more people will tell me, all those who realizing this. So guys, that is nothing but that is depicting what is the amount of dopamine activity. So if there is less color, if you can see in the A, that means there is less activity, and you can already tell me that which one belongs to the person suffering from Parkinsonism. That is the person A. Okay, thanks for so many responses. I'm loving the enthusiasm. Thank you. Now let's discuss some of the clinical features. I won't take much of your time, don't worry. Okay, I will be very, very quick. Guys, these are the main clinical features which you need to remember for sure. Tremors are happening and they are resting tremors. Okay, when you will start doing a thing, at that moment the tremors will stop. Okay, you can differentiate with different disorders. I will not discuss that. Okay, I've mentioned that in the PPT, as you can see. Then there is rigidity. Okay, certain rigidity for movements. Okay, you will feel some obstruction is there. You won't be able to move freely. Okay, the next thing that you need to know is bradykinesia. Mind you, this is the most important clinical feature which is always present in the patients of Parkinsonism. Okay, and you will not, this is something that you are required. Okay, if you are knowing about this, then you will be able to differentiate it from other diseases. Clinically, this is the most important, bradykinesia. Even though we think that it is tremors, but no. Then postural instability is also there. Okay, then tremors, as I've already explained, pill rolling tremors, okay, which will are present at rest only. Okay, and then very interesting thing is the cogwheel rigidity. So guys, what is cogwheel rigidity? That when you will try to move your arm, I don't know if my video is visible or not. Okay, when you will try to move your arm, okay, let me come in the view. Then it will keep on stopping in between like this. If you're trying to move, then it will stop. Okay, it is not lag in my video. I'm actually stopping my hand again and again. Okay, so while you're trying to move your hand, then there will be various pauses in between. Okay, and that is what we call the cogwheel rigidity. I'm still getting answers. I'm so happy about that. I hope the clinical features are quite clear. Okay, because now I'll be moving on to treatment and management of this disease, and then the doctors will be getting the second case. I won't discuss in much detail, but levodopa, which is probably presently the most effective medicine available for this. Okay, because it is a precursor. Okay, levodopa is nothing but a precursor to dopamine. Okay, but the problem is it has very high amount of side effects as well. But these days, to avoid the side effects, we are combining this with dopa decarboxylase inhibitor. So I hope all of you will remember. All of you will remember LD, that is levodopa or L-dopa, and you will also remember dopa decarboxylase inhibitor, that is DDI. Okay, so is that clear, all of you, this treatment? Because other than that, we have other treatments as well. Sorry for the color problem over here. Yeah, so guys, the surgical treatment is also possible, in which we do palidotomy. Okay, as we know, the globus pallidus has been is involved in this. GPI is for internal part of the globus pallidus, and GP is used for the external part. Okay, so we can remove a part of it so that we can see lesser effects, okay, of this and lesser symptoms. Other than that is a surgical approach to implant a dopamine secreting tissue, mind you, because we know dopamine is less in the body, so we can transport a tissue either directly from some other part, such as adrenal medullary tissue, or we can use stem cell therapy as well. Using both these therapy, we will be putting in more tissues, which is going to help in the overall improvement. Okay, now let me move on to the second case. So are you all ready for the second case, doctors? Yes or no? Reply in the chat box, please. Yeah, that's great. All of you are ready. So I will be reading. I'll be starting with the second case now. So guys, this is the second case. Again, he's a 57-year-old professor at a medical school, mind you. So please be quite cautious while treating him, है ना? Because he is having more knowledge than you. What happens is he is expressing suffering from excessive daytime sleepiness. Okay, even though he is getting a full night's sleep. Okay, please don't say that you are also suffering from this then, because he's also experiencing mental cloudness, a lack of energy, concentration, memory lapses are also present, and also a depressed mood. And a very important feature, please listen carefully, is sudden loss of muscle tone. There is sudden loss of muscle tone, sorry for the pronunciation, that is leading to the weakness and loss of voluntary control. Okay, and there are also brief episodes of sleep paralysis. I'll be explaining that shortly. So the first question, okay, you can see the symptoms at the left-hand side also, if you were not able to listen during the case presentation. Cataplexy is the loss of the tone. Then we have sleep paralysis, depressed mood, and daytime sleepiness, even after getting a full night's sleep. Can anybody tell me what is the probable diagnosis? It is an interesting case, I guess. So nice. Partial limbasi, I can see the answer, and it is narcolepsy, and I'm getting a lot of answers from Soumya Rath as well, and Malapati also, Nikita. So I think, yeah, so I think all of you already know, very intelligent crowd, I think. I hope I'm telling you something new as well. So guys, the probable diagnosis, as most of you are correct, is narcolepsy. I'm so happy. So many of you are replying. Very good, guys. Keep up the enthusiasm till end. Okay, and the second question for you now, because I think the first one was too easy for this crowd. So let's start with this. This is a multiple correct, mind you. So more than one question can more than one point could be correct. Okay, so the four options. Okay, you have to tell which one is valid to narcolepsy. Is it sudden onset of REM sleep, or sudden onset of NREM sleep? And is in this condition is more than usual hypocretin, which is also known as orexin producing neurons are present in the hypothalamus. Okay, or does it have a hereditary basis as well? It is a multiple correct, mind you, so please be sure. I will be waiting for a few moments. I can see a lot of answers. I'm so happy, so I'll be waiting for a few moments. Let me give you some time to answer. Amazing, guys. Amazing. A lot of responses. I'm so happy to look at that. Beautiful. Let me tell you the answer now. I hope all of you are ready to see the answers. And guys, it is both A and D. Okay, guys, it is not the sudden onset of NREM sleep. Okay, uh, when you are going to sleep, you know it starts with NREM, then it shifts to REM and like that and comes back. But in this, you are suddenly going into an REM sleep, guys. Okay, and C point is wrong because in this hypocretin, maybe you must be remembering. Okay, there was some hypocretin in narcolepsy, but it is less in these patients. I'll explain in a few moments. And yes, it does have a hereditary basis. So C point is wrong because less should have been there instead of more. And B is wrong because in this there is REM sleep, guys, not an REM. It is N for not REM. Okay, it is just REM. Okay, now let's come to the explanation. So as you can see, I've taken it from the Sleep Society, the picture. Okay, certain people have genes. That means it has hereditary basis. One point is clear. What happens is, guys, in childhood or teenage years, there can be something which triggers the disease. Okay, like we have cancer genes as well, and it can be triggered by something such as tobacco smoke. Similarly, narcolepsy can be triggered by infections. Now, what happens is this is an autoimmune disorder, and the immune system will start attacking on the cells which produce hypocretin, which is also known as orexin. And now, because of this less amount of orexin or hypocretin, you will see what all symptoms. Number one, sleep attacks. Okay. And then you will also find cataplexy. I've already discussed all these, so I will not go into much detail. Then also hallucinations is very, very important. Why? Because you will be dreaming. You will be suddenly dreaming and you will feel like you are hallucinating. Okay. And then sleep paralysis is very, very important and quite normal in the patients of narcolepsy. Okay, sudden sleep paralysis will occur. Okay, and there are certain attacks of these. It is not like you will be sleeping throughout the time with paralysis. Okay, there are attacks of sleep paralysis happening during the daytime. I would like to focus on the genetic basis of this disease. Please remember chromosome 6 is involved. Okay, how many of you have heard about HLA complex? Can anybody tell me where is it involved? The histocompatibility complex. I'll be waiting. Even if you're wrong, it doesn't matter. Please reply in the chat box. Anyone who knows, yes, immune system, very good, Kalpana. Okay, and yes, immunity. Tanya is also telling about rejection. Amazing, Tanya Nagpal, a friend of mine. So yeah, she's quite right that this HLA system is actually something which is actually recognizing your body and the other body cells. Okay, it is trying to recognize both of these, your body cells and the other body cells. Okay, and it is the most of the genes for it are located on chromosome 6. This particular problem, yes, graft rejection is the perfect term I was looking for because there is problem in that, and graft rejection can occur due to cell mediated immunity. So guys, HLA-DR2 and HLA-DQW1 loci, you know, is the location on the chromosome where the problem is there. So guys, at those two positions, if there is some problem, then you will be genetically susceptible to have narcolepsy. Okay, now treatment and management of this disease. Okay, so obviously if narcolepsy is there, so we will give certain stimulants, especially modafinil has been seen, but in severe cases we have other things also like sodium oxybate. Okay, and we also have dixaphetamine. Okay, sorry for the mispronunciation. Okay, and also we have selective serotonin uptake inhibitors as well. Okay, and for cataplexy, even though not approved, people have been giving drugs which are used for anxiety, etc. Okay, so they were not approved, so I did not mention, but it is there in various medicine books. Okay, moving on to the third case. Are you all ready for the third case of Panda Clinic? Yes or no? Reply in the chat box. Yeah, I can see Pranjal answering, and we have a lot of people answering now. I'm looking forward to discussing this case 3. So all the doctors are quite ready to cure either diagnose. Okay, curing also will do. We are learning treatment as well. So let's discuss the third case. I'm so happy that you are sending so many answers, guys. The third case is of a 70-year-old woman. Okay, what happened is very, very unfortunate. She fell down a flight of stairs, guys, and she hit her head on the concrete sidewalk. Now, what are the symptoms that we saw after she fell and hit her head? Okay, one thing, the trauma caused severe intracranial hemorrhage inside, obviously in brain damage, that will result in brain damage. And because of this injury, now what is being observed is that she is ignoring her left side. She is ignoring the left side of her body. Like she will only wash the right side. Okay. And then also she will only read the half right side of the page. She will only dress the right side of her body properly. Makeup sirf aadhe muh pe. Okay, she will only do makeup on half of her face. Yes, Uma, very good. It is hemi neglect. Oh, okay. I should not have said the answer loudly. Anyone else? We have another name also with the same. I will be waiting for your answers. The first question, you can see the symptoms on the left hand side. Yes. So what is the condition called? Yes, yes. I'm getting very nice answers. Pranjal has given. Advita has given. Very good. Soumya is also telling a lot of answers. Yeah, yeah. It is. Hemiplegia is the wrong word, guys. I'll be telling you that also. She is okay. She can walk. She can talk. She has all her senses are all right, but she cannot actually do anything with her left hand side. Okay, she is actually ignoring that whole side, even though it is working properly. So it is not hemiplegia, mind you. Yes. So I've got a lot of answer. Both the answers which I was looking for, I've got. Very amazing crowd today. So guys, the answer is unilateral inattention. Okay, because only one side is being ignored, also known as hemispatial neglect. Most of you were correct. Okay, obviously it is not paralysis because she is moving around quite nicely. Okay, the next question is which part of the brain was most likely damaged? Mind you, this can result from damage to various parts of the brain, but I'm asking which one is the most likely one. Anyone who can tell me? Any guesses? You have gone through the whole anatomy of CNS, I guess. Okay, we have an answer from Chirag. Anyone else who would like to try? I've got a very, very amazing answer, but the side is wrong. I'll be waiting for a few more seconds. Okay, I've got a lot of correct answers now, so I'll be switching to the answer. And guys, the answer is inferior parietal lobule of the representational sphere. Okay, those of you who are discussing representational right now, I'll be discussing it in a few moments. But remember, the damage is to the parietal lobule. It has been observed that if there is damage to the parietal lobule, then this has been observed most of the times, hemi-neglect syndrome. Okay, and it will happen on the side opposite. Okay, if the damage is on the right side, then the person will ignore the left hand side, and that is quite understood. We know the brain spheres are controlling the other halves of the body, most of it. Okay, let's move on to the explanation of this case, guys. Don't worry, I won't take much of your time. I hope you're enjoying the session. Okay, so let's discuss the explanation of hemispatial neglect. Okay, I'll start from very, very basics. I know all of you are quite knowledgeable, so I'll still, this is something that I wanted to do for my own gain. So, guys, we know that there are two sides of the brain, left and right. Okay, and we used to call it dominant and non-dominant, but that is wrong. It is not like ki half of your brain is useless. Okay, guys, we are having now the new name is categorical hemisphere and representational hemisphere. Now, please see that categorical hemispheres, okay, which used to be called as the dominant ones. Yeah, yeah, you will get the PPT. Don't worry, Abshar. Okay. If categorical hemisphere is responsible for, please see the diagram, not what is written. Okay. Sequential analytical processes. The categorical hemisphere is for sequential analytic processes. Now we will share that Shikhar, this is so complex. What is the sequential analytic process? I'll say it is nothing but your language skills. It is your right hand control. It is your reasoning and scientific skills. Okay. Now, if there is lesion on this side, on the categorical side, which used to be known as the dominant side, okay, as you can see, it is the left hemisphere in right-handed people. Okay, I hope now it's more clear. Okay, not don't directly say left or right. Say it is the left hemisphere in right-handed people. Okay, and right in left-handed people, the categorical hemisphere. Okay, like I am right-handed, so my categorical hemisphere will be the left one. Okay, so in this, if there is a lesion, then there will be aphasias, which are language related disorders, as have already been discussed. Okay, and if I'm talking about the other side, that is representational hemisphere, guys, that is responsible for visuospatial relations. Now, what is this VSR? That is visuospatial relations. Nothing but left hand control. The other one was right hand control. Okay, I'm not saying that visuospatial relation is left hand control. I'm also trying to cover other functions of representational hemisphere as well. Okay, like music awareness, art awareness, insight, imagination. Okay, all the things which attract you to a person, they are here. Okay, other than the sapiosexual people. Let's move on to the next one. So I've already, sorry for the last statement. Yeah. So I was discussing already aphasia has been discussed quite nicely, even agnosias. So I will not go into much detail. I hope that's all right with you. Okay. I will just tell you that, guys, agnosia, mein what is happening? You are having intact, everything is intact. Okay. But due to certain damage, okay, your sensory modality, I mean to say, everything is intact, then no disorder will happen. Your sensory modality is intact. Okay. Your vision is working fine. Okay. But even though that all is fine, you are not able to recognize the objects like in visual agnosia. Okay, by looking at the object you cannot tell. Please look at the picture on the left hand side. By looking at the picture, she cannot tell they are keys, but after touching, she can tell they are keys. Okay, why so? Because her she's having a visual agnosia. Okay, she cannot perceive what is lying on the table. Okay, the another thing that you should know is representational hemisphere. Okay, that is the non-dominant, which you used to call the non-dominant one, just for the sake of representation. I hope now it will be, you will remember what is categorical, what is representational. Okay, if there are lesion in this, then there can be astereognosis. Okay, and this is the ability to identify objects by feeling them. Okay, and there can be other agnosias as well. Okay, so anybody can tell me now in the chat box ki damage, which part suffered damage in this woman? She suffered from damage to which part? Anyone in the chat box? I've already discussed. It is there on the screen also. I love to see answers in the chat box also. Yes, damage to the representational hemisphere. Very good. And to which part, which lobule? Thank you so much for the responses. You are very, very nice. You are answering. I was thinking I will just sitting down and people will ignore me like they do usually. Let me continue now. So lesion of inferior parietal lobule, as all of you are sending the chat box, which will help you in a long run. The more you type, the more you listen, the more you remember. Okay, even though I do not use it, but that is something that teachers say, so I will also say that. Okay, so if there are lesions in inferior parietal lobule, then okay, and I hope you know that this is a region. Let me use my this yellow part you can see now. This is the inferior parietal lobule. Okay, in the posterior part of the parietal lobule, the inferior parietal lobule is located, and damage to this, okay, it can cause unilateral inattention. Okay, now let's come to the treatment or management of this. So guys, for treatment, very, very interesting. The problem is due to time constraint, I won't be discussing in much detail. Okay, but please go through this. Very interesting. I've added the link in Word document as well. That's prism glasses can cure this. Okay, so what is happening in prism glasses because of these? Okay, a part of the vision, okay, from the ignored side will be projected on the side which is all right of the retina. If I am sounding complex, then please go through the paper which I've sent. Okay, but I've tried to tell it in the most basic statement. Okay, and another treatment is eye patching. Very, very interesting. Again, I was so amazed to know about this thing. So what we are doing is we will cover the same side of each eye patch. Okay, we will be covering the same side of same side of the eye using an eye patch. Okay, and that will lead to the shift of the whole visuospatial attention to the ignored side. Okay, even again, this is a very long concept, and if I'll go into detail, it might take time. But if you have doubts, you can always send that in the chat box, and we can send the answers afterwards. Okay, so we are covering one part of the eye, both the eyes, mind you. Okay, so what will happen is up half of the parts, the stimulation is going to decrease. The second diagram is about when there is lesion. So as you can see, no brain activity is happening. Okay, in this part. But when I will be patching both the eyes, which is the third diagram, after patching the same side of both the eyes, can you see the dotted lines over here? The dotted lines means that side has been patched. Okay. Okay. Now what will happen? There will be stimulation of both the sides. I hope you understand that if patching is there on this side, then there won't be any perception on the other side. Because we know the object in the temporal side of our vision, they are projected on the retinal side. Okay. Again, a concept which has been discussed already. So I think that was all from my side. 3 cases. I do have an extra case. Do you guys want to do another case? But we have, or if you have time constraint, I can skip that.
We can do one case if everyone wants to.
Okay, okay. So I'll be very, very quick. I hope that's all right. So guys, another case for the amazing doctors that we have over here. Very, very amazing crowd again. So guys, the case is that she's a 30-year-old woman. I think all of you will tell me. Okay, and she has lost her left leg in a car crash. Okay, and then now she's claiming that she's experiencing the pain in her missing leg, mind you. The leg which is not there, she's experiencing pain in that. I'm getting so many answers already. The amputation happened 2 years ago. Okay, because it has been showcased in so many serials as well. I'll mention that also. So what is the syndrome called? Already I have so many answers. It is the phantom limb syndrome. But the question is, what is the physiological basis? It is a multiple correct again because I wanted you to cover most of it. Guys, which one of these do you think is the cause for a phantom limb syndrome? Not particularly for this patient, but for any patient. I'm getting a lot of amazing answers. Soumya is and Anagi and Vamshi are sending great answers. I would say even Amasti. Okay, so yes, the options are: is it the development of a neuroma at the site of amputation, mind you, or is it projection of regenerated fibers on the cortex, such that we are feeling the pains at the site where the receptors were supposed to be. The receptors are not there where they were supposed to be. Or is it alteration of pain pathway at the dorsal horn? Let's see the answers. A lot of you have replied in the chat box. I'm so happy. And guys, interestingly, I hope you won't beat me after this, but the answer is all three. There are actually the problem is there are so many theories to explain the phantom limb. I had to include all of them, but don't worry, I'll tell you the most acceptable one also. As Rocktem Hazarika is telling very nicely that A, B, C, all three are possibilities. Okay, and now let us move on to enumerate the treatment and therapies. Anybody who can tell me any therapy they have witnessed? Anyone who sees Grey's Anatomy, there was a therapy used for Arizona Robbins. Sorry for being going off topic. Treatments. I'm looking for treatment. Anyone who can tell me a therapy which is being used? Stabbing in the foot. Okay, that's an interesting answer. I'll wait for a few. Mirrors is being used. Very good. We have acupuncture. Mirror is something which is everyone is sending. I'm so happy because that is one part of the therapy. Yes, yes, and I think I'll be showing the answers now because you're quite enjoying this responses. Yes, lot of you are saying mirrors, and guys, that is the answer. For management of the pain, I'll be giving pain medications. Other than that, various therapies like spinal stimulation, I'll be explaining that in a few moments, don't worry, and mirror therapy have been used. Other than that, a number of therapies, okay, depending on who the patient is, have been shown, like have worked. But okay, but again, they don't work on everyone. So let's discuss the explanation. 70% of the amputees are suffering from this. Yes, Abchar, psychotherapy can help in case it is all psychological. But as I will be telling you, it has a lot of biological basis as well. Okay, maybe the placebo effect will help. I don't know. Let's discuss the theories. A lot of theories are trying to explain why this pain is occurring in a place which is not there in your body. What is actually happening over there? So, guys, one is that there is development of neuromas. Okay, they are very very painful. Okay, because of the accumulation of neurons at the site of your amputation. Okay, and because of this, even you won't be able to get a prosthesis, so it has to be got removed using surgically. Okay, another very less accepted theory, that is number two, is the cooling temperature dependence. Some people, some theories have stated that severity of this pain depends on the surrounding temperature. Okay, so that's why that is also seen that cooling of the nerve endings has increased the rate of firing of these nerve impulses, and that is leading to perception of phantom limb pain at the site, okay, which is not there in your body. But again, these are not the most acceptable one. The acceptable one is the central theory, which I'm telling you guys. So Malzek said this. So let me tell you in very very basic words. In your brain there is a neuromatrix, okay, and it is having certain functions. Okay, if one part of my brain, okay, just a silly example, consider me not an MBBS student for the next 30 seconds. Okay, so a part of my brain is responsible for speaking, just one part. Okay, now what happens is if I'm not speaking any longer, so will that degenerate? No, it is going to reorganize. The neuromatrix present at that location is going to reorganize and will start doing some other function. That is what this guy is saying, Malzak. Okay, but now see, read the language and understand why can it cause phantom limb pain. So guys, when the limb is being removed, then again there will be reorganization because that part of brain is not being used, so it will be assigned something new. But what happens, the neurosignature, the function which it was producing earlier, the kind of sensation that it felt at the site of location, it is going to experience that still, because the neurosignature has not been erased totally. So even if the stimulation is at some other place, the person is going to feel pain at the site of this amputation. Sorry. Okay. This was the central theory. Okay, and the most acceptable is this only, that degenerated fibers. Okay, another theory is degenerated fibers. They're going to project on your cortex. Okay, now what happens is they are projecting. Okay, because anywhere during the path, if I'm stimulating, still it is going to project to the cortex and produce some sensation. Anywhere during the path of the neurons. Okay, so even though the receptors are not present actually, but the neurons, due to some reason, get stimulated in between somewhere. Okay, then also I'll be feeling the pain at a location which is not actually there. Okay, this was the central theory, guys. Coming to the spinal theory, there is a alteration in the pain pathway of dorsal horn. So a sensation of another region can be felt over here. Okay, I could not include all the things because of time constraint, but you can also study phantom sensations, because not just pain, you can feel various sensations, like women who have undergone mastectomy. They have a lot of phantom sensation. Even people who have got their eyes removed, one of the eye removed. Sorry. Yeah. What was I telling now? The treatment. Yeah, so for treatment, nerve blocks, okay, anti-neuropathic medications have been suggested. Then surgical view to remove the neuroma, and then the spinal cord stimulation. Okay, nothing but electric current will be passed through the electrode, okay, near your spinal cord, okay, and that is going to stimulate your pathways, the electric current. Now what happens is this interferes with the impulses which are going to your brain. Okay, now because of that current, the impulses which were causing pain will be lessened. Okay, and now you will not feel more pain. That is how it works. Now we have mirror therapy. Okay, I think all of you know. Do you know who is there in the picture? Anyone who can tell me? Owen Hunt. Yes, very good. Yeah, so all of you know him, I guess, and he is looking at the leg of Arizona Robbins. Very nice therapy. So the mirror therapy is again a rehabilitation therapy, guys. Okay, and what we are doing is we are giving the illusion of the movement in the affected limb. Even though even I could not understand the precise working mechanism, and neither could most of the scientists. That how is it working? But yes, it has shown good effect in many patients. So that's why I tried to include it in my PPT. I think that was all from me. Any doubts, please feel free to send that in the chat box. I'll be coming back to them. I'll be passing on the mic to Gaurav. I hope you enjoyed the cases, and thank you, doctors, for doing such amazing diagnosis. I'm very, very happy with all my friends over here in the meeting. Thank you. Over to you,
So,
Koshu.
so thank you, Shikhar. It was a great presentation. Was amazed to see such a nice presentation. So guys, here we are today at the last day for the central nervous system. So we are going to conclude the system with a pop quiz. So it will be just a set of 15 questions based on what we have learned this week, and you will be given 30 minutes. So we will be sending out the link for the pop quiz soon in the chat box. And yes, I request every one of you to attempt this. And if you don't know the answer, it doesn't matter. We'll be discussing each and every questions after the quiz. So Gnomes, can you
uh,
please share the link?
all the participants, it's a
Yes.
general request that please attend all the questions. You will not be judged on any answer that you have marked wrong, but please make sure that you attend all the questions because this will be counted as your certificate in your certificate criteria. If you do not fill the questionnaire or if you do not attend the quiz, you will not be awarded a certificate. So I see 163 participants here. I expect all of them to fill the quiz, and we'll give you 30 minutes and all the answers will be discussed. Yes, Gaurav.
Yeah, I'll just send the link, Nishant. I have the link. I'm just sending the link to the Google form in the chat box, guys, just for you guys.
Sure.
Okay. Guys, if you have any issues with the link, let us know. It should work. And please make sure that you enter your names in the same format you did in the pre-event. Thank you so much. It's working great. Perfect.
So chalo guys, start answering.
And don't worry about the marks. That is a criteria just for post-event questions, which will be given tomorrow, or sorry, after today's event, and will be open for like a day. So don't worry about that.
Yes, Avanti, I'll send the link once again.
Hi guys, for a few of you asking, once everyone's attempted the quiz, like I think once the time's up, we will very quickly discuss all the answers. So I request all of you to hang in there. I have received around 70 responses until now. I'm still waiting on quite a lot of you. So please make sure you fill the Google form because only people who have filled the quiz will be assigned certificates, and we are closing the form after the deadline, which is in a few minutes. So please, we'll be closing it like in 25 more minutes. So please make sure you attempt the quiz.
Nishant and Kosha, can we leave now or is the call going on?
We are just going to discuss the answers after the time is up so that all of you understand what the correct answers were and what were the reasons for those. So we highly recommend that you stay on call, at least till then. It
Okay,
will take
bro.
only a few more minutes.
It's okay if you have filled the form and if you want to leave, it's fine. But if you want to stay back and be there for the group discussion, be there for the discussion of answers, you can stay back. No. Post-event questionnaire will be sent on the WhatsApp group after this call, and it will be open till tomorrow. So
For people who are asking if they can leave, it is up to you guys. We are discussing the answers too. So we would highly recommend you stay so that you know why the correct answers are the way they are. But if you really need to leave, it's up to you guys. And the minutes will be added accordingly.
Five more minutes and we'll be closing the form. So last 5 minutes. last 1 minute, and we are closing the form then. I hope everyone has filled. Those who want to leave, if you do not want to attend the discussion, you are free to leave. If you want to attend the discussion as to why your answers were correct or why your answers were wrong, you can stay back. And the post-event questionnaire will be shared on your WhatsApp group after this call at 8 p.m. Okay, so we'll start with the discussion. Gaurav.
Just a second. So, is it visible?
It's starting up. I think it will take 2 seconds. Yeah, it's visible.
So, hello everyone. I forgot to introduce myself. My name is Gaurav Agarwal, and I am a second crop student from the Medical College and Hospital. So, it was amazing to see so many responses. Great job, guys. It seems our effort was worth it. So, we will be starting with the last two questions first. So, Akash and Dhruvi will take that part. So, Dhruvi, you can start.
Okay, so this question, I hope you all have read it. I'll just start with the points which we have to discuss in this. So first of all, what will you read in the question is that it is an 8-year-old male and they have recurrent pulmonary infection with some neurological symptoms. Now, the most important thing here is that his gait is unsteady and he often loses his balance and he falls. And the language development as well is not very good. And apart from that, the patient's father says that the child's eyes and head did not move smoothly. So these are all, the characteristic features of cerebellar ataxia. So I discussed one of the cerebellar ataxia as ataxia telangiectasia. So in that, the main three prominent features were first is cerebellar ataxia. Second is telangiectasia, which means that the blood vessels in the eye and the other body parts will be very prominent. And the third most important feature is immunodeficiency, which means that the patient is vulnerable to sinopulmonary infections. So these three are the main important features of the ataxia, and in this we see that all the three are present. For cerebellar ataxia, you see that the gait is not proper. And you also see that the patient has recurrent pulmonary infections as well. So, what exactly is ataxia telangiectasia? It is basically an autosomal recessive form of ataxia, and that occurs because of the ATM gene. ATM stands for ataxia telangiectasia mutated gene, which is responsible for the DNA break repair. So the correct answer of this would be DNA break repair.
Thank you, Dhruvi. So moving on to our next question, Akash will take this part.
Yeah, so hi guys, I'm Akash, and basically I taught MS on day 2. So the question is, a 32-year-old woman comes to the office due to left eye pain that is accentuated by ocular movements. She also has periodic dimming of vision in the same eye. and the patient has had several such episodes over the last month, most often after a hot shower or intense workout. So basically, you could pretty much come with a diagnosis from these first two lines. So the typical history is of a woman between the age of 20 to 40, and woman because it's an autoimmune disease, and the symptoms are pointing towards an optic neuritis like picture. So the first thing that you should suspect in such a patient is definitely MS. And uh, a phenomena I told about, the Ertov phenomena, which was specifically abnormal heat sensitivity, which is most often after a hot shower or an intense workout. So we can quickly come with a diagnosis with these, basically the first two lines in itself. I'll discuss the other options as well, that why the other options are not valid. So the first option is atherosclerosis. So atherosclerosis of the carotid arteries can actually cause transient ischemia, leading to episodic vision loss. However, it would not typically cause eye pain or worsening symptoms with body heat, and would be very rare in a young patient without other signs of atherosclerosis. Then option B, brain mets, can cause a variety of neurological symptoms as well, but it would be expected to worsen with time and not relapse and remit like seen in this case. Option C is of course correct, demyelinating plaques, because that's basically the pathogenesis of multiple sclerosis. The fourth option is polycythemia vera. Yes, it can cause transient visual disturbances, but there are no other supporting symptoms for this condition. And the fifth option is neurosyphilis, but basically but in neurosyphilis there is no pain with eye movement or vision loss. And in addition, heat sensitivity and upper extremity weakness would be unexpected in neurosyphilis. The last option is vitamin B12 deficiency, which causes subacute combined degeneration of the spinal cord, and patients can develop a broad-based gait there. However, in most cases, this is slowly progressive and often accompanied by paresthesias in the distal lower extremities. And intention tremor and optic neuritis are not seen in vitamin B12 deficiency. So therefore, the answer comes out to be demyelinating plaques, even if you try to do it with the method of elimination.
So thank you, Akash and Ruvi. So I will be taking the rest of the questions. In case you went wrong somewhere, you can check out. So starting with the first question, which of the following is connected to the structure marked as A in the image below? So first we need to identify what is the structure A. The structure A in the given diagram is the splenium of the corpus callosum. So the body of the corpus callosum arches posteriorly and ends as a thickened posterior portion called the splenium. So, and this splenium is connected to the striate cortex. So the fibers from the splenium forms the forceps major, and it arcs backward into the occipital lobe, that is the striate cortex. So the answer for this question is option C, striate cortex. So now coming to the next question, which of the following descending tracts in the spinal cord remains uncrossed? Tectospinal tract, rubrospinal tract, vestibulospinal tract, pyramidal tract. All these tracts are examples of descending tracts. I think you are familiar with. So the answer is option C, vestibular tract. We all know, we have all heard about the desiccation of fibers in the spinal cord, but one tract which doesn't desiccate among the descending tract is the vestibular spinal tract. See, you can see here, all descending tracts desiccate except reticulospinal and the vestibulospinal tract. So now coming to the third question, a 34-year-old male was brought to the emergency department after he suffered a severe head injury in a road traffic accident. Radiography revealed traumatic brain injury causing damage to the midbrain at the level of the superior colliculus. All of the following tracts are likely to be injured except medial lemniscus, spinal lemniscus, trigeminal lemniscus, lateral lemniscus. So the answer for this question is option D, lateral lemniscus. We know what is superior colliculus. What is superior colliculus? It actually lies posterior to the brainstem, right? So only lateral collicus is not seen at the level of the superior collicus, and therefore it is not susceptible to injury in this case. It is a part of auditory pathway and ends at the level of the inferior colliculus of the midbrain. Coming to the next question, I think most of them had this question correct. So a patient presents with the inability to form words but can make noises. However, he knows what he wants to say. Identify the area of the brain that has been damaged in this patient. So you can see it's Broca's area, pretty simple. The structure marked in the image is Broca's area 44, 45 of cerebrum, which is damaged in this patient. And we know that patient can form words, but he cannot speak fluently, right? So coming to the next five number, a 24-year-old man incurs head and neck trauma in a motor vehicle accident. He now has impaired pain and temperature sensation from the shoulders down to his feet, but the proprioception and vibratory sense is preserved. He has motor weakness with muscle atrophy starting in his hands and extending to forearms and shoulders. An MRI of the cervical spinal cord shows a transverse slit-like cavity extending from the level of C2 to C7. So what is the most likely diagnosis? You can see the options, and the correct one is option E, syringomyelia. So the syrinx is a tubular defect that extends laterally, disrupting the spinothalamic tracts and the anterior horns, producing sensory and motor deficits. So when the cavity extends in the medulla, it is called syringobulbia. There is no definite treatment for this, but the lesion tends not to progress. Unlike we just studied Parkinson's disease, that's a progressive disorder. So among the rest of the options, Dandy Walker malformation, it is a congenital condition with an enlarged posterior fossa, diffuse axonal injury. It involves a white matter tracts in the cerebrum, and rachitis is a large open neural tube defect. Spinal bifida is a posterior neural tube defect. So guys, I have a question for you all. Can you name a teratogenic drug that causes spina bifida? You can type it in the chat box. Come on, guys, it's a teratogenic drug that causes spina bifida. Like when the woman is pregnant, if she's given that drug, it may cause spina bifida in the fetus. You're all correct. Thalidomide. Also, there's few more drugs like valproate can also cause spina bifida. So coming to the next question, which of the following cancer types has the highest propensity to metastasize to the brain? Breast cancer, lung cancer, melanoma, prostate cancer. So among this, the correct option is melanoma, the option C. The preferred response is melanoma. It is actually a cancer type with the highest propensity to metastasize to the brain. So 50% of patients with advanced melanoma eventually develop brain metastasis. That is so final, okay? Lung cancer actually accounts for the greatest number of brain metastases overall. As we know, lung cancer is quite common, but advanced melanoma has the greater propensity to metastasize to the brain than lung cancer. So now coming to the next question. A 22-year-old man presents to his physician with facial drooping. He reports this symptom began approximately 1 day prior to the presentation. He denies any trauma to the face and past medical history is non-contributory. On physical examination, there is facial drooping on the right side of the face. The right nasolabial fold is absent, and he is unable to close his right eye or raise the right side of his forehead. So the rest of the neurologic exam is normal. So which of the following is not a differential diagnosis for this condition? Stroke, Bell's palsy, GBS, trigeminal neuralgia. So the correct option is trigeminal neuralgia. Trigeminal neuralgia, actually it is a chronic pain condition that affects the trigeminal nerve, which carries the sensation from your face to your brain. So if you have trigeminal neuralgia, even mild stimulation of your face, such as from brushing your teeth or putting on makeup, may trigger a jolt of excruciating pain. So guys, can you tell me the drug of choice to treat this condition, trigeminal neuralgia? What is the drug of choice? Come on, guys, type in the chat box. Carbamazepine, absolutely correct. So actually, what is this? the actual action potential propagates, right? So to stop action potential from propagating, what do we actually need to do? We need to stop the neurons from depolarizing. And what is the main ion that is involved in depolarizing? It is Na plus ion. So carbamazepine, it's a Na plus channel blocker, and so it's the drug of choice for treating this condition. Coming to the next question. A 69-year-old male presented with diplopia. Investigations revealed an aneurysm of the anterior inferior cerebral artery on the right side that is directly impinging on the nerve arising at the pontomedullary junction. Which of the following extraocular muscles is likely to be paralyzed? Superior oblique, inferior oblique, medial rectus, lateral rectus. So it's pretty simple, guys. Answer is lateral rectus. We know all the extraocular muscles are innervated by cranial nerve 3. Only the two exceptions, that superior oblique is innervated by the fourth cranial nerve and the lateral rectus is innervated by the sixth cranial nerve. Coming to the next. A patient presented with weakness of the right side of the face with a loss of pain and temperature, and pain and temperature sensation of the left leg is also lost. So one is the ipsilateral and one is the contralateral. The lesion is most likely located at the medial medulla, lateral pons, medial pons, lateral medulla. Answer for this is lateral pons, option 2, lateral pons. It's actually the above clinical scenario is suggestive of lateral pontine syndrome. We have already discussed about it, which occurs with a lesion located at the lateral pons. So, and lateral pons occurs due to, and actually lateral pontine syndrome occurs due to the involvement of anterior inferior cerebral artery. We have discussed this already, so not going into the detail. Coming to the next question, a 50-year-old male came to the hospital with a severe headache. CT scan revealed an aneurysm of the internal carotid artery within the cavernous sinus. Which of the following nerves is likely to be affected first? Trochlear nerve, abducent nerve, ophthalmic division of the trigeminal nerve, maxillary division of the trigeminal nerve. Guys, this question is frequently asked in Vivas also. So the correct answer is abducent nerve. Actually, abducent nerve passes in close proximity to the actually passes within the cavernous sinus and in close proximity to the internal carotid artery. And the rest of the option, the oculomotor nerve, the trochlear nerve, and the ophthalmic division of the trigeminal nerve, they lie in the lateral wall of the cavernous sinus, and maxillary division of trigeminal nerve has nothing to do with the cavernous sinus. वो अपना ही चलता है. So after coming to the 11th question, a 63-year-old male presented with signs and symptoms of essential tremor caused due to the progressive degeneration of the cells that form the output of the cerebral cortex. Which of the following cells are affected? So it's pretty simple, guys. So the cells which forms the output of cerebral cortex, that's the Purkinje cells. And don't get confused between the Purkinje cells and Purkinje fibers. Purkinje fibers are present in the heart. They are really fast, very fast conducting cells. So neostratium consists of we already have discussed about the basal ganglia. So I think most of you have this correct. So it's the correct option is option D, caudate nucleus and putamen. You can see what all the basal ganglia consists of. It consists of the corpus stratum. What does corpus stratum consist of? It consists of the caudate nucleus, putamen, globus pallidus. What does lentiform nucleus consist of? Putamen and globus pallidus. You can see the diagram, globus pallidus and the putamen. This structure is the lentiform nucleus. So putamen forms the outer structure of the lentiform nucleus, and the neostratium, the caudate nucleus. This whole is the caudate nucleus, you can see, and the putamen. This is the putamen. So, coming to the last question, the blood supply to the structure marked in the image is by vertebral artery, internal carotid artery, anterior cerebral artery, middle cerebral artery. So this is a pretty easy question, guys. You just need to identify the structure. It's the fornix. You can see the depression, the fornix. So fornix is actually supplied by the anterior cerebral artery. So so to be more specific, it is supplied by the anterior medial central branches from the anterior cerebral artery, which not only supplies the fornix but also the optic chiasma, lamina terminalis, hypothalamus, para olfactory areas, and the cingulate gyrus. So with this, guys, we come to the end. So we are done for today, and actually this whole system.
Thank you so much, Gaurav. Thank you so much, all the
guys.
participants. Thank you so much, all the participants, for staying back with us, attending all the sessions. I hope you actually enjoyed all the sessions, and I hope your knowledge and confidence is a little bit better on the topics of CNS before and after the event. And we'll be sending out the post-event questionnaire in the groups, and we'll open the group for your feedback. So you can provide your feedback if there was any problem with the content, or if you would like to suggest any changes, or if you would like to provide any positive feedback. We'll just open the group so that you can provide us your feedbacks. And thank you so much. That concludes us with the week of CNS. Please stay in the groups. Please do not leave the WhatsApp groups, as all the certificates will be distributed there by the end of this month or at the start of next month. We'll evaluate all the forms, that is the pre-event questionnaire, the quiz that you gave today, and the post-event questionnaire that you will be filling after this. And those who have filled all the 3 forms as well as attended at least 75%, that is 3 out of 4 webinars, they'll receive the certificates by next month, at the start of next month. Once again, thank you so much. Thank you to all the local officers for presenting such great content, and thank you so much to the national team, Kosha and Shafati, for staying throughout the call. Thank you so much.
Thank you so much for the feedback, guys. We shall see you next week if you are a part of the next system. And do send your feedback on the groups before we send the post event. We'll really appreciate it. Thank you so much.
Thank you so much, guys. I'll end the call. Thank you so much for staying with us. Thank you so much.